And I would like to introduce, last but not least, Dr. Iolanda GARCIA. So she's a dear colleague from the research and development team in Igenomix, Spain. I believe Dr. Garcia is already online with us right now.
Hello.
Buenos dias, Yolanda.
Buenos dias. Hello to everyone.
Just a brief context about Dr. Garcia. So she completed her PhD in biomedicine and biotechnology at the University of Valencia and the Igenomix Foundation. Now she works with clinical diagnosis as an endometrial specialist at Igenomix headquarters in Spain, evaluating both endometrial receptivity and the microbiome. So welcome, Dr. Garcia.
Thank you very much, Vivian, for your kind presentation. And thank you for having invited me to participate in this webinar. I'm glad to be here today to share with you our last article entitled Endometrial Microbiota Composition is Associated with a Reproductive Outcome in Infertile Patients. We already know that there are different factors that are important for implantation. For example, the genetic status of the embryo, the maternal-embryonic crosstalk, endometrial receptivity, or decidualization. However, after controlling these factors, we still have some patients that don't get pregnant. And even if they do, they suffer a miscarriage. For this reason, we consider to evaluate other factors that can affect the success of the pregnancy. And we evaluated the microbiome because, as you know, there are a lot of bacteria living in our body. The Human Microbiome Project revealed that about 9% of the total human microbiome is found in the female reproductive tract. Historically, all microbes were believed to inhabit only in the lower portion because the cervix was considered a perfect barrier that maintained the sterility of the uterus. However, the emerging evidence demonstrates the presence of bacteria in the upper genital tract. Specifically, it has been reported that the genital tract is an open system with a continuous microbiota that gradually changes through the reproductive tract. Microbial communities have been found in vagina, uterus, cervix, fallopian tubes, and ovaries, with a decreasing bacterial abundance and increasing bacterial diversity as we move forward into the upper genital tract. In fact, it has been reported that the uterine microbiota has between 100 to 10,000 less bacterial load than a vagina, resulting in a low abundance bacterial community, also known as a low biomass microbiota. However, there is no consensus on what the physiological composition is, and sometimes it's difficult to define deviations leading to specific disorders. But well, there is really an association between the endometrial microbiota composition and the reproductive outcomes in infertile patients. During the 20th century, several groups using microbial culture of the distal tip of the embryo transfer catheter associated the isolation of Lactobacillus with better chances of reproductive success. In contrast, the isolation of endometrial pathogens such as Enterobacteria, Streptococcus, Staphylococcus, E. coli, and gram-negative bacteria was associated with significantly decreased implantation and pregnancy rates. Recently, several studies have used sequencing technologies that are more sensitive techniques that allow the detection of bacteria that cannot grow under standard culture conditions. And these studies have attempted to investigate the relationship between the endometrial microbiota composition and the RT outcomes. Both the study from Moreno in 2016 and the study from Kiono in 2018 found that a reduction in the Lactobacillus abundance, along with the presence of pathogens, was associated with poor reproductive outcomes. The study from Moreno in 2016 analyzed the impact of the endometrial microbiota on the pregnancy outcomes in 35 IVF patients with recurrent implantation failures, in whom the receptivity was analyzed using the ERA test. And the results of this study show that patients who had a live birth had higher levels of Lactobacillus, which is the blue color, compared with those who suffered a clinical miscarriage or who did not become pregnant, where the level of pathogens such as Gardnerella or Streptococcus and other reproductive tract pathogens were higher. In this study, the endometrial microbiota was classified using as a cutoff the 90% of Lactobacillus, and it was observed that patients with a non-Lactobacillus dominated microbiota present a significant decrease in implantation, pregnancy, and live birth rate. The evidence of this reproductive outcome was also observed in a couple of clinical cases. For example, this case report described the endometrial microbiota over 18 months in an infertile patient with repeat reproductive failures involving an ectopic pregnancy and 2 clinical miscarriages. The sequencing results revealed that this patient had a persistent infection with Gardnerella, and during this period, for different reasons, the patients took several antibiotics, but the infection did not remit. And the sequencing results also allow us to detect Gardnerella resistant clades with genetic features that could explain the antibiotic resistance and the reproductive failure observed. It's important to highlight that this study is the first longitudinal study that evaluated the microbiota several times in the same patient. In this case, in a total of 6 endometrial fluid samples. And in addition, this study is relevant because the last endometrial fluid sample was collected in the same cycle of the embryo transfer, just a few days before, reflecting that the status of the endometrium at that specific moment in a context of miscarriage. By contrast, in another case report, we describe as an incidental finding the endometrial microbiota in an early successful pregnancy and before a clinical miscarriage in the same patient. And interestingly, the endometrial microbiota at 4 weeks of gestation present a profile clearly dominated by Lactobacillus, whereas the endometrial fluid associated with a clinical miscarriage after the personalized embryo transfer with euploid embryos present a higher bacterial diversity and lower Lactobacillus abundance. It's important to know that this sample was taken without knowing that the patient had conceived spontaneously, and the patient provide the written informed consent for the analysis of the samples and the publication of her case. And well, again, against this background, we decided to perform a much larger study that we have published this year in the journal Microbiome. This was a prospective, observational, and multicenter study in which we used 452 infertile patients that evaluated the window of implantation using the ERA test in order to receive a personalized embryo transfer. At the same time that the endometrial biopsy was collected for ERA testing, on day 5 of a HRT cycle, an endometrial fluid was also aspirated, and both sample types were used to assess the endometrial microbiota by 16S sequencing. The main objective of this study was to determine whether the endometrial microbiota composition is associated with the reproductive outcomes. And for that, the bacterial profiles of patients with live birth were compared with the profiles of patients with unsuccessful outcomes. And these are the clinics that participated in this multicenter study. Specifically, we have recruited patients from 13 centers in 8 different countries. And it's important to know that the prospective study presented here is the largest published to date. Of the 452 patients assessed for eligibility, 44 were excluded from the analysis for different reasons, and 66 were lost to follow-up. Thus, finally, 342 patients were included in the final assessment. Of these, around 42% did not have a pregnancy, and about 58% become pregnant. And from pregnant women, 141 had a live birth, 27 had a biochemical pregnancy, and 28 a clinical miscarriage. In addition, 2 patients had also an ectopic pregnancy, but this reproductive outcome was not considered in the final analysis due to the small sample size. As I mentioned before, the endometrium has a low abundance microbiota. For this reason, before starting this study, we performed a stringent analysis to ensure that contaminating reads did not interfere with downstream analysis. After amplifying the 16S bacterial gene, we observed that there were samples with a higher amount of bacterial DNA, whereas there were samples in which the amount of bacterial DNA was equivalent with the blanks. And we observed this in both cases, in endometrial fluid and endometrial biopsy. So, in order to obtain a clear and clinically relevant bacterial profile that have an impact on the reproductive outcomes, we decide not to include samples with such low biomass. And we only include endometrial fluid and endometrial biopsy samples with a detectable microbiota. On the other hand, in order to obtain reliable profiles, we follow the methodological recommendations for endometrial microbiota studies. And we apply other measures such as the filtering of contaminating taxa. We use the prevalence of taxa in blanks as a method for identifying the contaminants, and in each dataset we remove the low abundant genera that are not significant and that the genera that not colonize humans or are associated with environmental contaminants. So after applying this criteria, we evaluated a panel of 15 taxa in endometrial fluid and 19 taxa in endometrial biopsy. The taxonomic analysis show a close relationship between the microbiota in endometrial fluid and endometrial biopsy. From all the taxa analyzed, 12 were common between both sample types, being Lactobacillus, the major genus detected in both, which is here in purple. However, some differences were observed because 3 genera were only identified in endometrial fluid and 7 genera were only detected in endometrial biopsy. A possible explanation of this difference is that the bacteria present on the surface of the luminal epithelium are different than those present inside the tissue that are close to the glandular epithelium or stroma. And moreover, these differences could be due to also different processing and DNA extraction protocols because differ between both sample types. As I mentioned, according to the literature, the Lactobacillus abundance is usually associated with better reproductive outcomes. However, there is no consensus on the amount of Lactobacillus established as a threshold. In this study, we assess their dominance, evaluating the difference between Lactobacillus and the other taxa analyzed in each sample. And in both sample types, we observe a higher Lactobacillus abundance in patients with live birth, in contrast to what happens in patients with biochemical pregnancy and clinical miscarriage, where the dominance of the other dysbiotic and pathogens were observed in both sample types. The predictive probability analysis also showed differences in the density intervals for each RT outcome. As you can see here in the graph, patients with live birth, that are those with the blue bars, are more likely to have a higher abundance of Lactobacillus because are more on the right, the interval is higher. Whereas, and this probability was especially discriminative for endometrial fluid samples, where the intervals overlap less with unsuccessful outcome intervals, that are those that are more on the left because have a lower Lactobacillus abundance. And finally, we evaluated the reproductive outcome, the reproductive impact of the bacterial community by establishing confidence interval for each bacterial taxa. We consider that the microbiota composition in patients with live birth is the physiological scenario, as does not interfere with the reproductive potential. For this reason, for each taxa, the values detected in patients with live birth were considered as normal and were compared with the values of patients with unsuccessful outcomes in patients with biochemical pregnancy, clinical miscarriage, and without pregnancy. For commensal bacteria, we expect a higher distance below the confidence interval, as these commensal bacteria, they will be found in lower abundance in the group of patients with poor reproductive outcomes, will be in lower abundance in patients without pregnancy, with biochemical pregnancy and clinical miscarriage, compared with the values detected in patients with live birth. While for pathogenic or dysbiotic bacteria, we expect a greater distance above the confidence interval, because in this case, they will be found in higher abundance in the group of patients with poor reproductive outcomes. Thus, we generated a confidence interval for the 15 taxa evaluated in endometrial fluid, and similarly, we established confidence intervals for the 19 taxa evaluated in endometrial biopsy. And these are the results that we obtained. In endometrial fluid, the taxa with a significantly greater abundance than the established confidence interval were Atopobium, Bifidobacterium, Cryosebacterium, Gardnerella, and Streptococcus for patients without pregnancy, and Haemophilus and Staphylococcus for with patients with clinical miscarriage. In contrast, taxa with a significantly lower abundance than the established confidence interval were Lactobacillus and Microbacterium in patients without pregnancy, and Lactobacillus in patients who suffer a clinical miscarriage. In the endometrial biopsy samples for non-pregnant women, taxa with a significantly greater abundance than the established confidence interval were Bifidobacterium, Gardnerella, and Klebsiella, whereas taxa significantly below the confidence interval was Lactobacillus, along with other commensal bacteria, as Cupriavirus, Finegoldia, and Tepidomonas. For the other categories, patients with clinical miscarriage and biochemical pregnancy, the differences did not reach the statistical significance, maybe due to the small sample size. And on the other hand, when we evaluated the main bacteria that produce chronic endometritis, in the endometrial fluid, we observed a significant increase in Gardnerella, Klebsiella, and Streptococcus in patients without pregnancy, Enterococcus in patients with biochemical pregnancy, and Klebsiella and Staphylococcus in patients with clinical miscarriage. And in the endometrial biopsy, the levels of Gardnerella, Neisseria, and Klebsiella significantly increase in this group of patients. Interestingly, Gardnerella and Klebsiella were the only pathogens significantly enriched in both sample types, in patients who did not become pregnant after the personalized embryo transfer. And in summary, we can say that after analyzing the endometrial fluid and endometrial biopsy from infertile patients with different reproductive outcomes, we can establish a pathogenic profile associated with patients with reproductive failure. We found bacterial vaginosis and chronic endometritis bacteria. But in addition, we can establish a commensal profile associated with patients with live birth, where Lactobacillus stands out among other commensal bacteria. So in conclusion, we can establish a pathogenic profile associated with the reproductive failure. And it seems that patients with a higher abundance of lactobacilli are more likely to achieve a reproductive success. Therefore, the endometrial microbiota should be considered as a possible emerging cause of implantation failure and pregnancy loss. So concluding, the endometrial microbiota composition before the embryo transfer could be a useful biomarker to consider, offering an opportunity to further improve the diagnosis and the treatment strategies. And that's all. I would like to thank to all of those who have participated in this study, all the Igenomix research department, the participant sites, collaborators, and patients. And of course, thanks to all of you for your attention. If you have any questions, I will be happy to answer them.
Thank you, Dr. Garcia, for joining us and for your presentation. It was really interesting, actually. And we did receive a few questions from the audience, both in the channel here and from China. But due to the time, also, we want to stick to the program. So we selected one question to ask you.
Okay.
So the question is, there is two questions in one, actually. And the first one is, when to perform Emma-Ellis in the proliferative phase or in the luteal phase of the menstrual cycle?
Yeah, we always recommend to analyze the Emma-Ellis in the secretory phase, because it's between the day 15 and 25, because it's the moment where the microbiome is more stable due to the effect of the estradiol and the progesterone. Because you have to think, that near menses can grow a lot of bacteria in that conditions that are not producing a real and chronic infection in the endometrium. So they can give us a false positive result. For the reason, we recommend always to analyze in the secretory phase between the day 15 and 25. And also it's very important to analyze as in the cycle as close as possible to the embryo transfer, because the microbiome could change with the time, and there are confounding factors such as the sexual intercourse, the use of antibiotics that can change the microbiota. So it's very important to analyze it as close as possible to the embryo transfer.
Thank you, doctor. One last one quickly, because it's also like a common doubt among customers, and that is, how many days before embryo transfer is probiotics recommended?
Well, I'm not sure about the dose and the instruction of the probiotics, because I think that it depends maybe on the probiotics, but I think that the probiotics don't hurt. They are good to restore the microbiota and to avoid the colonization with pathogens, but I'm not sure about the days when you have to stop it. I think that are not bad, so I think that it's not a problem. Maybe I can ask and set you better.
Sure, they're not detrimental to the development of the embryo. They would not be.
Yeah.
Perfect. Thank you so much, Dr. Garcia. We will close for the questions now, and appreciate you joining us today and the time and effort you put into your presentation. Thank you very much.
Thank you very much.